Hello, and welcome to the Academy of Online Radiology Education. I'm Dr. Aline Dikachikian, and I'm a radiology resident at McGill University. I'll be presenting on what's new in interventional radiology this month. I'd like to first take a moment to thank our senior editor. Our first article is titled Correlation Between Post-Procedure Residual Thrombus and Clinical Outcome in Deep Vein Thrombosis Patients Receiving Pharmacomechanical Thrombolysis in a Multicenter Randomized Trial. The study aims to find a correlation between the amount of residual thrombus on the immediate post-pharmacomechanical catheter-directed thrombolysis (PCDT) venogram and the patient's clinical outcome, notably their incidence of post-thrombotic syndrome (PTS). 317 patients, 200 of whom had iliofemoral DVTs and 117 femoral popliteal DVTs, were enrolled at 56 clinical centers in the United States. Patients had venograms before, then immediately after PCDT. Immediate residual thrombus was assessed by physician operators and independent readers. They were correlated with patient outcomes at 1, 12, and 24 months. PCDT successfully removed thrombus in acute proximal DVTs. 96% of patients had 50% removal, and 84% of patients had 90% thrombus removal. This study demonstrated that the immediate post-PCDT residual thrombus volume is not associated with less frequent PTS, and there was no statistically significant improved clinical outcome or valvular reflux. However, for iliofemoral DVTs, a lower residual thrombus volume was associated with a reduced 24-month PTS severity, with a moderate to severe PTS incidence of 8% in patients with complete lysis versus 19% in patients with residual thrombus. The study therefore questions the validity of the open vein hypothesis and encourages future research to understand the pathogenesis of PTS, with particular attention to how patency can be maintained over time. Our second article is titled Evaluation of the Benefit of Extended Catheter-Directed Thrombolysis with Serial Angiography for Acute Pulmonary Embolism. This study aims to determine if repeat visits to the angiography suite for extension of catheter-directed thrombolysis, CDT, is beneficial for the treatment of acute PE. This is a retrospective cohort analysis of 156 patients who presented with a massive or submassive PE within 14 days of symptom onset and underwent pulmonary artery CDT with RTPA and at least one follow-up visit to the angiography suite after the initial CDT. 111 treatments were terminated after a single follow-up, and 45 had additional follow-up visits. All patients then returned to the angiography suite after a mean of 19.4 hours for repeat pulmonary arterial pressure measurements, PAP, and pulmonary angiography to assess residual thrombus according to the Miller PE Severity Index. This was followed by a decision to continue or conclude CDT. CDT extending beyond the first follow-up visit required a higher dose of RTPA, 40.7 mg versus 22.6 mg, to achieve a final similar Miller score and a similar reduction in systolic PAP, 14.4 mm of mercury versus 12.6 mm of mercury. The systolic PAP and heart rate were significantly higher in multiple follow-up groups during the initial and first follow-up visits. All groups demonstrated a significant decrease in systolic PAP between initial procedure and subsequent follow-ups. In conclusion, threshold values of systolic PAP over 55 mm of mercury and a heart rate of over 100 beats per minute during the initial CDT may benefit from extended CDT to achieve similar improvements in systolic PAP and thrombus burden. Our third article is titled First in Human Study with 8 Patients Using an Absorbable Vena Cava Filter for the Prevention of Pulmonary Embolism. This is the first in-human study which aims to prospectively evaluate absorbable Vena Cava filters. 8 patients were enrolled over a period of 36 weeks. Patients either had proven DVT or PE and a contraindication to or failure of anticoagulant treatment, or required transient VTE prophylaxis due to elevated VTE risk and contraindications to anticoagulant agents. Once the absorbable filters were deployed, follow-up visits were scheduled at 5 weeks to assess PE in filter stent endothelialization, 11 weeks to ensure absence of thrombus before filter basket disintegration, and 36 weeks to compare the IVC before filter deployment and after filter resorption. Subjects underwent CT and abdominal radiography before filter implantation and 5, 11, and 36 weeks afterwards to assess filter complications. Possible PE was assessed with CT before and at 5 weeks after filter placement. In conclusion, the ease of deployment was similar to that of conventional endovascular device deployments. There were no post-procedural complications or adverse effects after 36 weeks of follow-up. Our fourth article is titled Evaluation and Management of Intermediate and High-Risk Pulmonary Embolism. This evidence-based review aims to overview PE treatment options to reduce PE mortality. There were two major guidelines that were reviewed: the 2014 European Society of Cardiology (ESC) guidelines on the diagnosis and management of acute PE, and the 2016 Antithrombotic Therapy for Venous Thromboembolic Disease (CHEST) guidelines. The authors emphasized the importance of initially classifying PEs using the ESC classification system, which defines a PE as high risk if associated with hypotension, intermediate high risk if associated with both imaging and cardiac biomarkers evidence of RV right ventricle dysfunction without hypotension, intermediate low risk if associated with either imaging or cardiac biomarker evidence of RV dysfunction without hypertension, and low risk if associated with none of those findings. This review states that patients with high or intermediate clinical probability of PE should be initiated on parenteral anticoagulation while workup is in progress. For intermediate risk PEs, systemic thrombolytic therapy can be considered if there is hemodynamic or cardiopulmonary instability. Percutaneous catheter-directed treatment or surgical pulmonary embolectomy may be considered if hemodynamic decompensation appears imminent and the anticipated bleeding risk with systemic thrombolysis is high. For high-risk PEs, patients should be promptly evaluated for systemic thrombolysis. If systemic thrombolysis presents high risk, is contraindicated, or has failed, catheter-assisted thrombus removal with or without catheter-directed thrombolysis or surgical embolectomy should be considered. Moreover, IVC filter replacement should be decided on an individual basis. Our fifth and final article is titled Acute Aortoiliac Occlusion in Patient with COVID-19 Infection. This is a case report of acute aortoiliac and lower limb arterial occlusions in a patient with severe COVID-19 infection. The patient is a 56-year-old male with diabetes, hypertension, and obesity who presented with acute muscle weakness and sensory loss in the left lower limb. An initial CT showed distal aorta and left iliac artery occlusions and a small thrombus floating in the aortic arch. There were also typical COVID-19 pulmonary findings. The patient was immediately taken to surgery for percutaneous right common femoral and open left common femoral approaches. Covered kissing stents were placed, and a completion arteriography showed left popliteal occlusion, which was treated by open popliteal thrombectomy. 30 minutes later, the patient showed signs of acute right limb ischemia, and a right open femoral approach was performed. The arteriography of the right lower limb showed popliteal and distal leg artery thrombosis. A new complete right below the knee thrombectomy was performed. A few hours later, CT scan showed a new thrombosis, the right popliteal artery extending to the distal arteries, and a new occlusion of the deep left femoral artery and no patent artery below the left ankle. A second right popliteal artery thrombectomy was performed. A third CT scan demonstrated that there was a new small right renal infarction. Moreover, a left transtibial amputation was decided after hemodynamic stabilization. The last CT scan showed complete lysis of the thoracic aortic thrombus. In conclusion, the mechanism of occlusion is thought to be embolization from a floating thrombus in the aortic arch and systemic inflammatory response caused by the viral infection. In fact, it is believed that COVID-19 induced a hypercoagulable state and an endothelial dysfunction. This marks the end of this month's updates in interventional radiology. Thank you all for listening.